Okay, good morning, everyone. Thank you for joining. We're just going to quickly try and share my screen and then we'll start. I'm going to share my screen. Can someone on the floor just confirm that they can see our screen? We'll share it now. Can the floor see our screen?
Yes, I can, yeah.
Thanks very much. Okay, good morning, everyone. My name is Dr. Louisa Brownell. I'm one of the ENT registrars here at UCT Cape Town. This morning, I wanted to just talk to us a bit about CSF leak management and sort of a little bit about how we do it at our institution. We did have a CSF leak repair that we took to theatre yesterday. It is quite a lengthy topic with a lot of different approaches. So I've tried to make it as concise as I can. I just want to acknowledge Prof. Darlene Libber, who's unable to attend this morning. A lot of the video content and images are from many of her presentations and also for her contribution to the presentation. As an introduction, CSF rhinorrhea is really, it happens when there's a disruption between the anterior and middle cranial fossa and your sinonasal cavity, and then it results in a leak, as demonstrated by the picture. It is rare, but it can potentially be devastating, with the most significant complication being meningitis. Other complications include intracranial abscesses and pneumocephalus. Under 1% of patients will develop meningitis after you've surgically closed and repaired that defect. Although rhinorrhea is the patient's most troubling symptom, the principal motivation behind closure of CSF leaks that don't resolve is really to reduce the year-on-year risk of meningitis. In 1926, Dandy really started looking at CSF production, properties, and circulation. And Dandy was actually the first person that successfully repaired it via craniotomy as early as 1926. In 1981, Vignant then added an endoscope to basically assist repair. And since then, our approaches to CSF leak repairs has changed relatively quite drastically. The biggest causes of CSF rhinorrhea, really 80% are related to trauma, around 16% are iatrogenic, and only 4% are neoplastic. And this is most commonly with your more invasive malignancies. The risk of developing meningitis is quoted as anywhere between 3 to 10% per annum. And the diagnosis is really a combination of clinical and lab-based. So historically, as we mentioned before, our management has greatly evolved. Traditionally, these were mostly managed by neurosurgeons, and they still have transcranial, transphenoidal approaches that often required extensive craniotomies and significant brain retraction. Since then, now with the endoscope, we can now do a lot more minimally invasive techniques and more directed access using natural anatomical corridors, of which there are many different new approaches. This helps to avoid retraction on the frontal lobe. It's reduced brain contusion, seizures, and olfactory nerve injury. It's reduced overall risk of complications. And as such, endoscopic techniques are preferred when this is a viable option in the patient. It has helped to decrease morbidity, and there is a high success rate of endoscopic.
Excellent presenter. Excellent.
There is a high rate of endoscopic success rates of 90 to 95% versus open procedures if in the correct, well-selected patients. This was just a systemic review of outcomes, and this conclusion was that you can achieve equivalent success rates with endoscopic approaches with lower post-operative mobility and lower rates of recurrences in carefully selected patients. So what are some of the management considerations? I apologize, it seems one of my pictures hasn't come up, but it's not too important. What are the management considerations in CSF rhinorrhea? The big call that you have to make is, are you going to manage this conservatively? Are you going to do it open, or are you going to do it endoscopically? We know that 80% of traumatic leaks will stop by around about day 7, and this lends itself to a conservative approach being very reasonable in the majority of patients. Pneumococcal vaccine is very useful, with PCV13 being better than PPSV23. It takes about 2 weeks to develop cellular immunity. You really want to try and prevent nausea, vomiting, coughing, blowing the nose as such, which can help to prevent leaks and also reduce your failure rates. If we operate on patients and have a successful repair, it lowers your cumulative 10-year risk of meningitis from 85% to 5%. At our institution, we no longer use routine lumbar drains, but there are some indications in which you may consider this. For example, in high-risk patients or recurrent spontaneous leak patients. Fluorescein is hardly used at our institution, but there are some indications in international literature and sometimes used at other institutions. Prophylactic antibiotics is no longer routinely given, but there are also some indications in which you may opt to change that decision. And there's the picture that I was actually wanting to show. CSF rhinorrhea, when we look at leaks, we've said that it's a communication between the subarachnoid space and the sinonasal tract. But you've got to remember that when you're examining these patients, you have to actually exclude that there's not concomitant drainage that's coming through your eustachian tube. It's largely classified into iatrogenic during functional endoscopic sinus surgery. Can also be due to trauma with penetrating or blunt trauma, and then there are the rarer congenital causes. We also have a subgroup of spontaneous CSF leaks where there's a leak into the lateral recess of the sphenoid sinus. The very classical features are clear watery nasal discharge. This is largely positional, and the patient might describe a gush of fluid on moving in an upright position. They tend to have headaches. This gets better when lying supine. And then obviously your classic features may be related to the complications that they have. As we said, most traumatic leaks will resolve with conservative management. But if you have an iatrogenic intraoperatively, you must repair that immediately. And a persistent CSF leak that continues to leak and leak also has to be surgically repaired. There are some easier leaks. However, easier is never easier, and it's always relative to the skill of the surgeon. But in essence, these would be leaks that you really have direct access to. Examples of these would be ones involving the frontal sinus, where you could consider an open approach. Those involving the cribriform area or the area of the fovea ethmoidalis. However, they are not always so easy to detect intraoperatively. And the question is always, what do you do if you have a completely normal CT, but you know that you have a confirmed CS leak coming from somewhere? These images are courtesy of Prof. Libba and demonstrates a 41-year-old female with serial slices on her CT imaging. Although the CSF leak was simple to fix, it was actually quite difficult to find preoperatively, even when evaluating her particular CT scan. This is actually where the leak was at the end. Iatrogenic leaks commonly occur if they are going to occur during surgical manipulation near the skull base. It can range from simple cracks to very large defects bigger than 1 centimeter. Neurosurgical intervention that can result in iatrogenic leaks are examples: craniotomy, particularly pituitary resections, and obviously neoplastic disease. From our ENT perspective, we may encounter an iatrogenic CSF leak when you're approaching the area of the lateral lamella, the cribriform, the posterior ethmoidalis, or the posterior aspect of the frontal recess, obviously in septoplasty with open manipulation and neoplastic disease. It's important to note that around half of your iatrogenic CSF leak patients can actually present within the first week after your surgery. So you may discharge them and then subsequently only develop problems. So it's quite important to educate your patient on salty or metallic taste symptoms and when to come back. In pituitary surgery, if we look at this specifically, if you're going to embark on pituitary surgery, in all cases, you have to prepare for a CSF leak. You want to really have the abdomen prepared for possible fat harvesting, and you want to pre-prepare a unilateral mucopericondyal septal flap. The flap is elevated in this area. This is just a video, I hope it plays, of pituitary surgery that did encounter CSF leak, which you can see quite clearly there. Okay, I don't think we need to spend too much time on that. Okay, if you see a CSF leak intraoperatively, you want to really repair that immediately. You can use intranasal tissue, and the areas where you may encounter leak is really related to the type of surgery. Your lateral lamella of the cribriform plate is involved in around 40% of cases. A defect in the frontal sinus is less commonly involved, as well as the sella tunica and sphenoid sinus, but this is all relative to the area that you're actually operating on, the initial intended surgery. Endoscopic sites of surgery are really your lateral lamella and the posterior ethmoidal roof. If we look a little bit more at traumatic CSF leaks, this is really the large bulk of the CSF leak causes that we see, especially in our population in our country with a very high rate of trauma. This can be due to blunt or penetrating. The patient we took to theatre yesterday was due to penetrating trauma. We can break them up into immediate or delayed, immediate being less than 48 hours after the injury. And this is really the vast majority of patients. And that's because you've got a bony defect and a dural tear. Delayed leaks can occur. So it's always important to ask our patients a good history, because they can occur even 3 months after the index trauma that the patients have experienced. Reasons for delayed leaks are really that you previously had an intact dura, and then very slowly over the period of a couple of months, it starts to herniate through that bony defect and it finally tears. And the second theory is that there is a tear and a bony defect that is actually present at time of surgery, but there's a lot of swelling and there's a hematoma there which actually contains it. And as that resolves, patients then begin to present with the CSF leak. Most traumatic CSF leaks will heal with conservative management. This will heal by means of a mucosal layer of closure in the defect, because dura will not sort of close that defect. It will not regenerate. So you could argue that it's a relatively fragile closure because it's only a mono layer of protection. So you may have ongoing risk of meningitis. And overall, the feeling is that there are relatively small risks of endoscopic surgery. So there has been a slight shift towards a more active interventional policy. Of course, if your patient has massive head trauma and you're starting to think about whether or not an open approach is more appropriate for your patient, and if there's other intracranial injuries needing surgery anyway, then it may be more appropriate to go for the open option. Our next big group is spontaneous CSF leaks, or previously deemed idiopathic. And this is really in a very particular subgroup of patients, generally middle-aged females with BMIs above 30 and obstructive sleep apnea. And that's because your dura is subject to very wide CSF. The leaks that occur are really a variant of benign intracranial pressure. There is a thought that perhaps they develop this because there's poor CSF reabsorption from the arachnoid villi. Due to the raised intracranial pressure, it causes sort of very thin areas of bone and weakening in these areas and subsequent leak. These patients could have multiple weak spots, and this is really the role where some institutions will use fluorescein to try and identify where there's an area of most active leakage, as if they have multiple spots, it's obviously going to be far more challenging to repair. It is important to note that sometimes benign intracranial hypertension diagnosis is really made after you've gone and surgically repaired a CSF leak, because preoperatively the leak actually reduces the pressure of the CSF, and the patients, after you've repaired the CSF leak, may actually then start to experience headaches and feel quite unwell. But preoperatively, you would also evaluate your radiological features for signs of raised intracranial pressure, of which an empty sella and enlarged ventricles are open to things that you may look for on a CT scan. Spontaneous CSF leaks are difficult to manage in the sense that a large portion of them actually reoccur despite repair. There are success rates for endoscopic repair are not quite as good as for other pathologies. And a few years ago, we looked at our repair rates in our success rates in spontaneous CSF leaks. And a few years ago, we were at around 50% of spontaneous CSF leaks recurring, but that is relatively in line with international literature. They can re-leak at the site that you've just tried to fix, or they can re-leak at multiple areas of the skull base. So it's really important that you've got to manage these patients' intracranial pressure as part of their treatment. And for that reason, you may consider something like acetazolamide. In very selected patients, shunting may be an option. Areas of substantial skull-based dehiscence may also benefit from reinforcement with a multi-layer closure and reinforcement with bone or cartilaginous graft. If there's the lateral recess of the sphenoid sinus involved, that's really where you may consider a different type of approach. For example, transpterygoid and more recently transorbital approaches have also been described. So if we look specifically a little bit more at the lateral sphenoid sinus CSF leaks, the question is this a true Sternberg canal as described in the literature? And we now know that it's not the true typical description of Sternberg canal. There's a very strong association with our middle-aged woman with a higher BMI and benign intracranial hypertension. Part of your workup will be confirmatory beta-2 transferrin testing, as well as imaging, and you should try and get fundoscopy done by your ophthalmology colleagues to look for any signs of intracranial pressure and papilledema in the eye. When we want to classify sphenoidal sinus leaks specifically, we can classify them either according to etiology or according to location. Etiologically, we've already covered the three main kind of categories. In terms of location, these can either occur in the midline, and they're usually described according to the relationship of the foramen rotundum, so either medial to it or lateral to it. It is really important to determine the cause of the leak, because post-traumatic leaks will often heal spontaneously, as we mentioned, whereas your iatrogenic leaks relating to pituitary surgery need to be repaired immediately. But in this particular subgroup, our spontaneous leaks are a whole different kettle of fish. And unless you are an experienced endoscopic surgeon and you have otherwise healthy tissue to see and repair the defect, you will have a high failure rate. That's just to demonstrate the foramen rotundum and the location and description of sphenoid leaks in relation to that, either medial or lateral. This is a video courtesy of Prof. Libber, and this is just a right sphenoid, so-called Sternberg canal defect. You can see the CSF leak pushing up and through that area. This is really one of the approaches, a transpterygoid approach, which allows visualization of that tricky to access area. And this is more of a schematic presentation to be able to wrap your brain around what type of defects you may want to repair and what the best approach may be to have the highest success rate. You may need different instruments, for example, 30 degrees lenses. That's where you may approach the transpterygoid. You may approach it from the contralateral transorbital side or from the ipsilateral transorbital side. At Curtis Hospital, our protocol for managing spontaneous CSF leaks up until about 2008 was endoscopic repair, lumbar drains post-operatively, CSF leak pressure monitoring, and a CT scan about 6 weeks with neurological assessment. We had a look at our success rates, and in our spontaneous group, around 50% were successful. The ones that had recurrences all had recurrences within a year, whereas the traumatic and iatrogenic repair rates were almost 100%. That was up until 2008. The patients that had recurrences, some of the causes that may be identified is that there was no amputation of a concomitant encephalocele, a septal mucoperichondral flap wasn't used, there was a small sphenoidotomy done, and there was, in one case, there was only fat plugging of the sphenoid sinus. So what is the current management of spontaneous CSF leaks at our institution? So our surgical management has changed because our access and routes has changed. We have better techniques now of repairing these leaks. We now do a more aggressive sphenoidectomy. We know that we have to amputate the whole meningocephalocele. You want to really identify a 360-degree circumferential defect if you're going to repair it adequately. You want to try and stop your leak with your first underlay fat graft as far as possible. We use mucoperichondral septal flaps based on the posterior septal artery, and post-operatively we implement bed rest. we make a decision on whether or not this patient is going to require a lumbar drain, if it's a high-risk patient or a recurrent patient, or if we're going to institute use of Diamox, and also what their long-term management might look like. For our central defects or during pituitary surgery, you want to hopefully identify the leak site. We place abdominal fat that we mix up with a bit of Surgicel to make it more surgically manageable. It tends to stick down a bit better when you've mixed it with a bit of Surgicel. We sometimes harvest cartilage and do a bit of a buttress repair, or we have used substances such as Duragen as an underlay. We use a mucopericondylar flap as an overlay. You can then also place Surgicel on top to hold up your flap. Sometimes we implement Duraseal, and occasionally we put rapid rhinos into the nasal cavity indicated. We did not place the rapid rhino into our patient from yesterday's CSF leak repairs. We felt that the flap was being held up quite well, and we actually used a portion of the middle turbinate to hold that flap up adequately. Of course, there is the alternative approach to the sphenoid sinus, which is our transorbital approach, and this is really an approach that has really changed the face of lateral recess CSF leak repairs, and probably in well-selected patients with experienced surgeons, this will probably be a technique that will be more widely used going forward, I think. This is just a short video, kind of a video on an approach to a lateral sphenoid sinus leak repair. So it's been summarized by Prof. Libber. As you can see, this is lifting of the mucopericondylar flap. You can see that the defect is identified. Sometimes by cauterizing, it can also sort of help to temporarily tamponade the flow if it's a very small leak. This is Prof. Libber doing a more transorbital approach. Transorbital approach often requires quite a few assistants. Lots of people working in a very small space, lots of teams working in a very small space. You can see that she's using some fat to plug the defect. Swab is placed on the top to help put that defect in. And that's the flap that's going to be placed over that defect area. I mentioned on congenital CSF leaks. These can be congenital skull-based defects or tumors. Embryologically, it's usually from the foramen cecum, or you may have a patent fonticulus frontalis. Actually, congenital CSF leaks with encephaloceles and meningoencephaloceles is actually quite uncommon. But if they do present, they can have intranasal mass, so you have to have a high index of suspicion, and you don't want to biopsy these intranasal masses until you have imaging, especially in a pediatric population. You may do an MRI to detect a skull-based defect. The brain tissue in an encephalocele is non-functioning, so that can actually be removed during surgery. And also, if you want a successful repair, you may need to remove that. If we look at tumor-related CSF leaks, benign tumors don't commonly result in leaks. It's more your aggressive tumors, like your inverting papillomas that erode through the anterior cranial fossa. Also, sometimes if you've had a patient that's been operated or had chemotherapy for their tumor, that can typically result in a leakage after their intervention. So if you're going to repair these during surgery, it's very important to have margins around your leak that have to be clear and free of tumor. So on our clinical assessment, as we mentioned, you're going to have a look for watery unilateral nasal discharge. You could definitely ask about a history of trauma. You are going to carefully ask about trauma, because you can have delayed fistulas, as we mentioned before. There are case reports of patients that have been misdiagnosed as allergic rhinitis with an ongoing watery clear nasal discharge. Really, they can have headaches that are relieved when the patients get CSF drainage. They can have an intermittent leak, a reservoir sign. That's basically where it starts to collect in the paranasal sinus, and then when they positionally change their head, there's a sudden gush. They could have episodes of recurrent meningitis, so just to be on the lookout, and they might have signs of raging pressure or visual acuity changes. Some useful things is you might ask about localizing symptoms. You know, if they're complaining of anosmia, you would consider perhaps there's an injury to the olfactory area or more to the anterior cranial fossa. if they are having visual acuity defects, that they may alert you to look in the region of the optic nerve. On clinical examination, you obviously want to do a full endoscopic bedside flexiscope, as well as a systemic examination. And you may ask them to Valsalva when you're looking with the scope, just to have a look and see if you can identify CSF leak. There is the Quinstead-Stuckey test by compressing jugular veins to see if that demonstrates where your leak may be coming from. And then bedside, in patients with head injury, it can be quite tricky because, you know, they obviously have a lot of pathology going on. They might be intubated, they might be in ICU, so it's not always as straightforward. But you may look for the halo sign. Just to note that the halo sign is not exclusive to CSF, so it can be false positive, but in essence, it's where you have your red blood that locates towards the center of a droplet on a sheet or litmus paper, and then you have CSF, which kind of creates a ring around that central reddened area. You should always consider whether or not there's even a bilateral CSF leak. This can occur when you have involvement of your midline structures, because the CSF can actually flow to the other side. By far, the most common findings with CSF arteria, about 30% of patients will present with an episode of meningitis, and then 30% may present with pneumocephalus. What lab studies can you do? We often look for glucose content. It's really rapid, but it's not that reliable. So it's not recommended for screening or as a confirmatory test. You get lots of false positive results. Glucose, yeah, so as I mentioned, you get lots of false positive results. In active meningitis, it can also drop your glucose level, and that may give you a false negative. So you can use it, but it's not recommended for screening or as a confirmatory test. It also doesn't give you an idea of where your site or size of the leak is. Beta trace protein has a good sensitivity and a good specificity, but just to note that it can be altered by other concomitant conditions such as renal failure or central nervous system tumors, and it's also not specific for the site or the size of the CSF leak. Beta-2 transferrin, which is what we use at our institution, is currently definitely the single best laboratory test. It's only located in CSF, perilymph, and aqueous humor. It's got a really high sensitivity and specificity. It's quite quick. The literature says it's quite rapid. In our experience, it takes about 3 days to come back. It's non-invasive. You need about 0.5 mils to make the diagnosis. It can be stable at room temperature for around 4 hours, but it should not be frozen. And it doesn't provide information about where the defect is. And you might have center testing restrictions, and obviously transporting lab specimen can also delay the diagnosis. Imaging is really core if you're going to manage CSF leaks. You want a CT with high resolution. That's the modality of choice, and that's going to help you identify possible cause, location of defect, and it may help your surgical planning for an appropriate approach, whether externally or endoscopically. If you see pneumocephalus, you consider that there may be a little dural tear, and you may even see an air fluid level in one of the sinuses. This is not diagnostic for CSF leak, but it may alert you. It may also help you to identify any inactive defects so that you can plan appropriately for your surgery. The coronal image is the most helpful, and other views can be helpful. MRI is not typically first line, but you would do this if you were suspecting something like an encephalocele. It's really expensive. It's time consuming. In our experience, it takes up to a few months to be able to obtain an MRI unless the patient's admitted as inpatient, and it may not necessarily be localizing. Cysternography is also described on T2 weighted imaging, but you could possibly also have a false negative if you have an intermittent CSF leak. For cysternography, they inject intrathecal contrast. We don't do this at our institution that I've seen, but it can show you where the active leak is. It is quite invasive, and there are side effects to this, for example, GIT upset. And then there are various nuclear medicine radioactive isotopes, which require administration, which require lumbar puncture, and then obviously serial scanning to see where the fluid has gone. Historically, I think at our institution, we used to do this where we place pledgets, and then you place the pledget in strategic positions, and then you would analyze that for any evidence of tracer. There is some systemic absorption and you can have false positives. So I think this has largely fallen out of favor, at least at our institution. Intrathecal fluorescein can help to diagnose and localize sites of leak, but it's not really FDA approved. You need to administer via an LP. So they take 10 mils of CSF that's withdrawn in a sterile manner. 0.1 mils of a 10% solution is diluted in the CSF. And then that mixture is re-injected into the subarachnoid space over 10 minutes. So it's all rules of ones. It's 10 mils, 0.1 mil, 10%, 10 minutes. The dilution should be a really slow injection because the risk here is seizures. And if you give it slowly, there's less risk. Intraoperatively, you can also use a xenon light source, which might help highlight that area, and a blue filter can also be used. So indications, so when are we going to surgically repair and when are we going to opt for conservative management? All patients with a spontaneous CSF leak should be surgically repaired. If it's intraoperative, if you cause an intraoperative leak, you should repair that immediately. If it's an iatrogenic injury, but it's delayed, then probably you should also go for surgical repair. In the role of trauma, there's room for 7 to 10 days of conservative management. After that, if it persists, then really you should consider surgical repair. And the risk is obviously meningitis if these leaks are not repaired. Year on year, we have a 10% risk of meningitis. And the most common organism, Streptococcus pneumonia, Haemophilus influenza. That's why if we have a confirmed leak, we give Pneumovac. The risk is highest the first 3 weeks after trauma. About 10% of patients will present with meningitis then. That risk jumps up to around 40% in non-traumatic CSF rhinorrhea. In conservative management, especially in trauma, we would advocate for this in the immediate onset leak. There is a really high likelihood of spontaneous resolution after 7 to 10 days of bed rest. You want to elevate the bed to 15 to 30 degrees. You want to put them on stool softeners, no coughing, no blowing, avoid vomiting. Should we be using a subarachnoid lumbar drain? It hasn't really been shown to decrease recurrence in the role of trauma, but in essence, they drain off around 5 to 10 mils of CSF per hour. They suggest continuous drainage rather than intermittent if you are going to use a lumbar drain. Certainly, if you're starting to insert lumbar drains, you need really good nursing care. You need people that understand exactly what a lumbar drain is, how much to remove, how to troubleshoot. So certainly in our ward, we don't use lumbar drains. If a patient does require a lumbar drain, then they go to a neurosurgical ICU where the nursing staff are more equipped and trained to manage this. In terms of leakage resolution with trauma, within a week, 70%, the huge majority of the patients are going to resolve. Within about 3 months, around 30%. And then within 6 months, most patients have resolved in terms of trauma. In trauma, the leak almost never occurs. So you have to weigh that up in terms of patients' risk for meningitis. Versus your non-traumatic patients, only about a third stop spontaneously, and they can have intermittent leakage over 7 years. So should we be using antibiotics if you confirm a leak? So there's no conclusive evidence that your prophylaxis will reduce your meningitis risk. Prior studies with antibiotics have had some mixed results. Antibiotics during endoscopic sinus surgery, I guess, is reasonable. There's no real good randomized control trials. Patients undergoing surgery often have underlying inflammatory or infectious pathology, so it is reasonable to give a stack dose of antibiotics intraoperatively. Should you be using diuretics? Well, there's been a few studies on this. So acetolamide may not aid in resolving your traumatic CSF rhinorrhea, and it may actually be harmful due to metabolic and electrolyte disturbances. This has been kind of looked at in the literature, but you just need to be aware that if you're going to embark on this, they can have quite bad side effects, electrolyte derangements, low levels of bicarb, potassium, and chain alterations in your serum pH. They can have GIT upsets, polyuria, and paresthesia. There's been a big shift towards endoscopic surgical repair leaks over the last 30 years. Intracranial repairs, typically that's done by means of a frontal craniotomy. You can use a free flap, you can use a dural flap, you can use pedicle periosteal flaps, muscle plug, and fibrin glue. But it's difficult to access your sphenoid sinus from an intracranial repair perspective. The advantages are, of course, if you're going to go in for other pathology in the brain, you can actually inspect the cerebral cortex. You can see it directly from above. The disadvantages are that your patient has significant morbidity, risk associated with it. They can have permanent anosmia. There's brain retraction, which may lead to seizures. And they have much longer post-operative stay. So it is an option, but they also have high failure rates for the first attempt. So if you can do these endoscopically, that is really the management of choice. Endoscopic approaches, we talk about transnasal endoscopic, and then you have combined approaches where basically you may opt for a combination of a frontal sinusotomy with endoscope, transorbital with endoscope. You may just need to tailor this according to the region of the leak. I think we've covered a little bit of the external approaches just briefly, but just to note that there are many described in the literature. It's too much to kind of cover in one talk. But this is not commonly embarked on by our institution. If we can help it, we prefer endoscopic repair. If there is a breach in the posterior table of the frontal sinus, you may consider doing a nice eyebrow incision and then doing a trephination of the frontal sinus and then combining that with your endoscopic frontal sinusotomy. The advantage of doing this endoscopically is that you have much better field visualization in most circumstances, unless it's very, very angled. You can magnify. It's a lot more accurate to place your grafts, good success rates. It preserves your overall bony framework. The lesions, can be some lesions that are in challenging locations, like as previously mentioned in the posterior wall of the frontal sinus, we may opt rather to do a combined approach. And then we mentioned the lateral sinus recess. And there you may consider doing a transpterygoid or even a transorbital approach. If it's all about whether or not you can get good access versus anatomical corridors. This is just an example of a frontal sinus CSF leak that was done by a combined approach, endoscopically, a Lothrop procedure. And in this patient, it was minimally invasive. There wasn't no need to obliterate the sinus and no need for a lumbar drain.
Mm-hmm.
So very nice. You can see very nicely by doing this in a combined manner rather than opting for craniotomy. This is the same patient, but perhaps for the sake of time, we'll just move on. Okay. There are several endoscopic approaches available. You can do transfrontal. This is where you have really the floor and the posterior frontal sinus. You want to be really careful around the frontal sinus tract to prevent mucocele development long term. But this helps to avoid obliteration with an osteoplastic flap. If there's defects in the more lateral and superior aspects, it's a bit more limited because of our current types of instrumentation. They all are instruments that don't really bend well to look around corners. So you want to really start with doing an ethmoidectomy. You want to identify the frontal recess, and you can widen it by doing an endoscopic Lothrop. And you really want a good panoramic exposure of the posterior table. Other endoscopic approaches we've briefly mentioned, there are many. Operative considerations at Curtis Ski Hospital, if we're going to embark on endoscopic endonasal, we really want an ENT surgeon and a neurosurgeon. You need to define the anatomical defect. You want to basically pre-measure the size of the cellar, if that's where the defect is. A buttress may help you and is beneficial in most cases. You're going to mix it with some Surgicel, a multi-layered closure. We don't do lumbar drains. We do a graded approach. Got to be careful of patients with high BMIs. This is just a picture of how you might prepare your patient. Good abdominal exposure if you're going to harvest fat, endotracheal tube off to the left side to enable your endoscopic instruments to have better access. You can see she's also had her nose packed preoperatively just for decongestion. You may want to set up neuronavigation. The head is good to be in a neutral position. You don't want to use a throat pack. And as we mentioned, you're going to prep your abdomen and your nose well. Intraoperatively, you're going to find a defect, and whatever way you need to expose the defect is what is appropriate for the patient. So you want to do ethmoidectomy, frontal sinusotomy, maxillary antrostomies, identifying good anatomical landmarks. Once you've seen it, you want to decide is there mucus still? If yes, then you want to resect that with bipolar. You just want to be careful because you don't want any intracranial hemorrhage. Sorry, we just got quite a lot of interference. You got to clear the mucosa around that defect so that you don't get future mucocele development, and you want a good margin of around 2 millimeters of exposed bone. Your defect is measured, and that helps you to plan the size of your flap and where you're going to take your flap from. Different grafts that we use, we can use free grafts that might be fat, temporalis or fasciolata, fascia, or even a free mucosal graft. Our pedicled flaps, we like to use the mucoperiochondral flap based on the SBA posterior septal artery. You may extend that to a lateral nasal flap, and you may even use a turbinate as a flap. We do use DuraGen or BioCol. It's really dependent on your surgeon preference, expertise, and experience at your institution. But it often involves multi-layered defects and a stepwise kind of approach to it. There are other ways of doing it where you can do a bath plug, and that's basically where you place a bit of fat and you pull it through until it seals it off very nicely. You can use bits of bone graft if you have larger defects, and as demonstrated in one of the videos before, typically we do this as an underlay, but that might be quite challenging to do. Yes, and then yeah, these are just, that's kind of our approach to it. And this is the pedicled flap, if you haven't seen it before. So this is being removed off the septum, the stepwise fashion. It's then sort of parked into the middle meatus while you're preparing. And then you want to identify your defect. You want to make sure that the length of the flap is long enough to reach the spot of the defect. You want to ensure really good, adequate hemostasis. You don't want to compromise your posterior septal artery. When you place this flap, you also want to prevent rotation. That's going to compromise that vascular pedicle. Maybe let's forward it a bit. And there you can see the flap has been placed. And then depending on where it is, you may use other structures to kind of support it, like a middle turbinate. Okay. Okay. The nasoseptal flap is also known as the Haddad flap. It's good to use if you have a sphenoid sinus, a sternochanal defect. You can use it for the whole anterior skull base. You can use it in clavichordomas, and you can also use it in pituitary surgery. You can decide whether you want to use an overlay or an underlay. They both have good success rates. There's no real difference between the techniques. The size of the defect may help you to think about whether or not you're going to do an onlay of mucosa or fascia. If there's a dural tear, you might want the composite graft is warranted, and there you really want to be doing a multi-layer closure. And if it's greater than 5 millimeters, you also want to do composite grafting. The mucosal overlay can be from septal mucosa, middle turbinate. In essence, you make 3 incisions. There's a vertical incision, a superior horizontal, and an inferior horizontal incision. It's attached posterior laterally, and the pedicle contains a sphenopalatine neurovascular bundle. An alternative to mucosal graft is alloderm. I haven't seen this. And your grafts can be anchored down with fibrin, gel foam, and some packing to kind of apply a bit of pressure to the site to hold your graft up. What is critical is that when you're placing that flap, whatever graft you use must not obstruct your other paranasal sinuses. So your graft must not overlie your sphenoid, your sphenoidotomy. It must not kind of be placed in such a way. So you really have to kind of, A, you have to open all your sinuses widely so you don't get obstruction by means of your graft. And B, you have to contour your graft. So you kind of want to move it in such a way that it's only really repairing the defect without obstructing any of the other sinuses. Okay, some more videos. This is a patient that had surgery before. This is prof liver removing the gel foam and then very clearly identifying the CSF leak. So we found the site of the leak. Now we're going to kind of assess the size. See Jura there. Looking forward to it. Okay, nice big leak. Okay. This is just harvesting the flap. I think we've seen this video before. Injecting with local on the septum and inferiorly. This is the same leak. This is making the flap 3 incisions. Being careful not to compromise your posterior septal artery. That's the flap being rotated in. Okay. This is harvesting a bit of cartilage. This can be quite challenging to do. This is being used as a buttress. You see there's a round knife that's being used to kind of gently pop this in through that defect, a bit like a plug. Okay, let's seal it very nicely. Last piece of cartilage in. Okay, there's some DuraGen about to go in. So it looks very nice. Not leaking anymore. Sealed up quite nicely. Just the pericondylar flap being placed on top. It's not twisted on its pedicle. It's placed very nicely. Okay, and then it's just being packed down with a bit of Surgicel. So in this case, they didn't need to place it kind of supported with anything else other than a bit of fat. Okay. All right. So at GSH, we identify the site leak, we mix it with Surgicel, harvest the cartilage, and do a buttress repair. May do a DuraGen, mucopericondylar flap, Duraseal, and then you might opt to use a rapid liner into the nasal cavity. Okay, when you intraoperatively, when you're going to wake this patient, you want to avoid nausea, vomiting, and they should always attempt deep extubation because you don't want them to cough or gag. They should, the anesthetist should be informed that they cannot bag the patient because you'll get pneumocephalus and it will worsen your leak. Post-operatively, if you're going to use a lumbar drain, you'll drain about 10 mils an hour for 48 hours. If they are known to have intracranial, if they're known to have a drain, you may opt to clamp it for after 48 hours for 6 hours. And if the opening pressure remains very high after that, you're going to consider diuretics. Follow up, you want to remove all the non-absorbable packing after 7 to 10 days. You're obviously going to look inside the nasal cavity to check if there's a leak. And then if you're using a Diamox, you want to check the electrolytes and look out for any adverse side effects. Controversies, lumbar drains, there's no real prospective randomized control trials. You have to evaluate the benefit of the drain versus the risk of having the drain and and if this is a high-risk patient. BP shunting, there's no real consensus, and prophylactic antibiotics, no conclusive studies. We don't use prophylactic antibiotics. So in summary, after a long lecture, some CSF leaks are challenging and require multi-layer repairs, but you must expose the defect with all leaks. You must expose it well. Your first layer of fat should ideally already seal the defect. And then we like to use vascularized mucopericondylar septal flaps. If you are going to use a drain, keep it closed, only drain 5 to 10 mils an hour for 48 to 72 hours. And you want to follow them up for benign intracranial hypertension, and you're only going to use Diamox after discussion with the neurologist. So I apologize, it was quite long, but there were lots of nice videos that I didn't want to compromise on.
Thanks very much. A few comments. That's a lot. That's not surgery for a small help.
It's not surgery.
I think the issues are, firstly, you put different figures right to talk about meningitis rates. Right early on, you say 1%, and then you go on 5%, 10%. The only different percentages you want to talk. So you must be consistent about that. The second thing is you can also get CSF leaks from posterior possibilities. You say early anti-middle. Okay, I mean, the classic one is acoustic neuromas surgery, some of the typical approach. That's actually quite not uncommon, so you should change that as well. And then the mutual pretty under that this way. Just go back one slide. The mucopericondylar action.
Oh, sorry.
Yeah, you must spell that in 2 places.
Sorry. Prof.
Yeah, and then they don't apologize, that we talk out there.
I'll change
meet
it
you,
before.
that's
I'll change it before.
And then I think the last issue is, I think you also have to be really practicing, because you might be more conservative with dramatically look in a sense where you don't have the expertise, all right?
Yes.
Here we've got the expertise, so
Exactly.
we can do it.
Yeah.
But I don't think everybody in the world should think they have to jump in and fix every season.
Yeah.
It's seems spontaneous, all right?
Yes.
Yeah,
Sure.
but we have to stick to that.
Yeah. This was quite GSH
No, but
focused, but
that's
you're
fine,
right.
but just
You're
you
right.
say that, yeah. You're fine, yeah.
Yeah, I think it might be useful to, it was a very nice talk, a lot of detail, but I think it might be useful to kind of identify the audience and realize that not all of us are necessarily angioscopic surgeons. However, some of us may need to do things if you're doing face, but you're not necessarily doing more complicated stuff. What things can you attempt based on your sinus and what would you invest and what would you definitely need neurosurgery backup for? I mean, that I don't know, I'm a neurologist.
Yeah, that's
But if
right.
I were working somewhere in the middle of nowhere where there isn't necessarily neurosurgical backup on site, and there isn't sort of, which one can I possibly attempt because I'm doing face every week.
Yeah.
And then the principles in that.
Okay.
And because I think that's useful, because you got to be in mind, not everybody has that kind of facilities available, and that's important. And then just the other thing on the vaccination, though, we only have at the moment, just to bear in mind, we only have the Prevnar 13. We used to have the Pneumovac, which covers the 23 different serotypes.
Yes.
Now we have the Prevnar 13, which only covers 13 serotypes. So there's a difference in the vaccination that we're giving right now for the last year, I think. We've only had the Prevnar available. So they're still restricted getting the other
strands.
the other serotypes. Okay. Yeah.
Cool. I'll rework it a bit, make it a bit more simple.
I must apologize, I was in and out, but I agree with what Prof said absolutely about the traumatic CSF leaks. So were you advocating that we should prepare all traumatic CSF leaks?
No.
Or should we
No.
still man wait 7 to 10 days?
I mean, I think international literature is very clear that conservative management is a good option. So I think that's
I thought
very
that was sort of consensus. I know that maybe you can clarify that in our unit there is a thought that perhaps repair, regardless of whether it's sealed or not, may reduce the subsequent risk of meningitis. But has that been proven?
I don't think it's been proven. And certainly with our case from yesterday, I had to ask. After the round, I did ask Prof. Libber about whether or not we should repair it. And she felt that there were a few things in this gentleman's history that sort of swayed our decision in one direction. And part of it was that she felt that we know that trauma-related CSF leaks have a higher risk of meningitis early on, so in the first 3 weeks. This gentleman had already received 4 days of antibiotics prior to him coming to us. So whether or not he was going to mount a response and demonstrate that he had meningitis at this point was unclear. And with our theatre lists being cut, she felt that if there was an ongoing leak, her concern was that we may not be able to necessarily have good access going forward to be able to repair his leak. And so certainly the case from yesterday, I think, was a combination of decision-making in terms of our current availability of theatre time, also our patients' follow-up, and the question whether or not he was going to mount a clinical meningitis having had 4 days of antibiotics. So that was for the case specifically yesterday. But international literature is very clear that you can reach 70 days of conservative management rather than.
Sorry.
And then, sorry, my last comment is also again from a resource point of view, just in your graded GSS quote, you kind of quoted Duragen.
Yeah, I thought about that afterwards. Very expensive.
Not widely available products.
Yeah.
And just, I mean, Darlene always emphasized that the most important layer and product is your autologous first layer. So again, they're obviously nice adjuncts to have, but they're essential as far as I mean.
Yeah.
Just from my experience with the traumatic CSF leaks, is usually if there's an associated bleeding injury, particularly if it's significant, then it's worth waiting at 7 to 10 days, because you find as the brain swelling reduces, that CSF leak automatically resolve. Not in every case, but in most cases. So if you wait, I very rarely have had to take every single, unless it's a massive posterior fossa leak, where there's been a massive defect, most of them actually just naturally. There was something else I wanted to tell you. Sorry, was the first part of your talk, you mentioned the middle cranial fossa courses.
I didn't, it was basically mostly focused on, it was definitely mostly focused on anterior cranial fossa. It was cross right, I didn't mention it, but it was too big.
It is 50% of your patients that present with CSF primary, right? So, and particularly with the spontaneous ones, if you're looking at the anterior skull base, and this is the thing, there can be multiple sites, it can be anterior or middle cranial fossa. And if you've repaired the anterior cranial fossa and it's still leaking, go and look at the middle cranial fossa, because you might find that there's another defect. So where the tympanic membrane is intact, you can present with CSF primary. And likewise, if you have an anterior skull base defect, you can present with a middle ear infusion. So that's just what the other important thing I think in your clinical findings. Because if CSF rhinorrhea, well, that could be open.
No, you're right. I should have clarified that. Yeah, no, you're right.
Importantly, you can scan. It is from the sinus.
Yeah.
I did probably that you can see this one. It's going to be like one of those sites.
Yeah.
It's going to be sure. But you should obtain like several things.
Yes. Any comments from?
Are there any comments from the floor? Sorry, no, that was quite a long presentation. I'll try to rework it before we put it up. Prof, I think Rose was on the chat, I think,
Thank you very much.
Thanks, Prof. Okay, if there's no more questions, we'll end the meeting and we'll make some minor adjustments to the presentation before putting it up. Thanks.
Can I see the case of a study there? You say that there's no randomized studies for antibiotics for case surgery. Maybe something to think about. We'll see how the outcome is. You should talk.
Thank you, everyone. Thanks for joining. See you next week.